that, I'm excited to turn it over to Dr. Fishman to get us started.
Well, great. Thank you so much. And welcome, everybody. Thanks for taking some time on a Friday to talk with us about young people, or youths, as we say in Brooklyn, I guess. And I'm going to be talking about how the world of substance use intersects in part with the world of mental health problems, but also approaches to dealing with substance use in young people. When we talk about young people, mostly talking about adolescents, but also, we're also including young adults or transitional age youth. The idea that adolescence doesn't kind of end at some magic chronological cutoff. I'm 18 and I'm all grown up. Rather, it's a dimensional developmental period of maturation or immaturity, either way. And the idea that we're thinking about some of the vulnerabilities and assets and approaches that apply across that part of the lifespan. Here's just a word about me. I'm a psychiatrist by training. I hope you won't hold that against me. I've specialized through my career in addiction and wear a bunch of different hats. My favorite is as a clinician working directly with patients across the lifespan, but including a focus on young people and their families. I also do program administration in a regional community treatment program in Maryland and do research in addiction clinical outcomes. So here's a bit of what we'll be talking about, kind of a whirlwind tour. Start with scope of the problem and how that impacts what we see young people using and the developmental vulnerability of this special period in the lifespan. A focus on cannabis, not because it's the most dangerous of the substances, but because it's in the news. It's one of the most common of the substances, because in our modern era, people are generally skeptical and pre-contemplative. It's not a drug anyway, so what's the big fuss? So just some discussion about that. A focus on treatment approaches. Obviously, we don't have enough time to get into depth about specialty treatment, but some overview of approaches that you guys who work primarily in mental health might think about in terms of importing and getting more comfortable with. Talk about the overlap in co-occurring disorders in specific, and then some focus on opioid use disorder and medications for opioid use disorder. Here, not because it's very common, it'll be a small minority of the patients you might encounter, but certainly it's a very high severity, important subset with the possibility of fatality, and an emphasis that we do have these marvelous tools, these medications that we use across the lifespan, but some people don't recognize how important and usable they are in the target population of adolescents. And then to conclude with some advocacy for the idea that we don't want to think about young people just as short adults, but rather tailor our interventions to developmentally informed or developmentally specific ideas. And one of the things that I want to concentrate on the most is my advocacy for family involvement as being such an important but underutilized tool. So let's start with a quick poll question just to get you guys thinking about where you are now in your interactions with adolescents and young adults with substance use problems. How comfortable are you with these dual diagnosis kids? You may know that they're using, you may not know that they're using, but certainly with the prevalences we're going to look at, I assure you that many of the youth that you're treating have these problems, whether you know it or not. So how comfortable are you?
Yes, so we do encourage you all to please fill out the poll. It should have popped up on your screen, so we're just going to have it up there for a little bit. As Dr. Fishman was stating, just let us know how comfortable you are. And while we give you a little bit of time for that, I do want to thank you all for joining. I've looked at the chat box, and it seems that we have folks from various programs and services, inpatient, outpatient, school settings as well. And folks from different just sort of roles and positions across New York State, and even just a couple from outside of New York State. So again, thank you so much for joining us. And again, please feel free to fill in the poll here, and we should have the results pop up in a little bit.
All right, well, it's great to see that most people are at least somewhat comfortable. Some of you very comfortable, some of you not at all comfortable, but thank you for being willing to put your toe in the water with me, those of you who are not expert, and come along for the ride. I hope I can persuade you that you should be more confident and work to gain confidence, that the only way to do this work is with enthusiasm and by trying it. And you won't break anybody, so come on in. The water's fine. So let's start with chapter 1, talk about the scope of the problem, and start with a quick perspective on development and developmental vulnerability. I'm going to be talking a lot about adolescent risk and part of the problems that young people face, and problems in vulnerability and problems in poor decision-making. And I just want to remind everybody that this kind of intergenerational perspective, when maybe you, me especially as an old guy, a gray beard, looking back in the rearview mirror, adolescence was a long time ago for me, and we're looking at young people and worried about them and what's the danger and what's going to be the pitfalls for the next generation and how much guidance they need. And this is something that repeats itself, just to remind you, in every generation. It's not new, but I want us to be careful a little bit. Although I'm going to concentrate on risk. Remember, adolescence is not just a time of risk. It's also a time of marvelous expansion and discovery and opportunity and rich growth. And so I don't want us to lose that. And I also want us to be careful, especially as we're working with adolescents and their families, not to devolve, as is sometimes the temptation, into the role of old scold. You know, the kids these days don't value a dollar. When I was a boy, we had to walk barefoot in the snow to school, uphill both ways. Right? That finger wagging is not helpful, even if it's correct. I'm not sure if it's correct, but it's not helpful. And I just want to give you this quote to give you an illustration of that. We live in a decadent age. Young people no longer respect their parents. They are rude and impatient. They frequent taverns and have no self-respect. Guess, when's this from? And, you know, the language might be a giveaway. I mean, I suppose it could be last Tuesday, but what do you think? And I was surprised. Look at this. This has been going on for a long time. But, you know, the risk is real, and that's what we're going to concentrate on today. But we want to also be thinking about narrowing the gulf, narrowing the generation gap, and giving these messages in a way that are digestible to young people. And as I say, not perceived just as scolding from a dizzying height. All right, so what are young people using? Here's some epidemiology about that, but notice it's the trends in non-use. So it's use on its head, the reciprocal, same information, but presented in a different way. And the reason the authors of this paper did this work, and I think it's so innovative in terms of non-use, is to address a very typical response from adolescents and their families. When you talk to them about their substance use, they say, "What are you bugging me for, Dr. Fishman? Everybody uses. I'm no different. I'm just like everybody else. It's everybody." Well, if you look at the data, is that actually true? So look at the cannabis line, for example, one of the topics we'll be talking about and one of the most common substances. About 50%, this is, by the way, lifetime use in 12th graders, not necessarily problem use, not addictive use, not current use, but ever used. So approximately 50%, 60%-ish of 12th graders have had at least one lifetime use of cannabis. It's a lot, but it ain't everybody, right? Look at cigarettes. Plenty of kids smoke, but many fewer, and the increase in non-use is one of the great public health successes of the last century, not just in young people, but across the lifespan. And if we took this data back another 50, 60 years, you'd see how far we've come. Take a look at the bottom line, all substances. 30% of high school seniors have never in their lifetimes used any of these substances, alcohol, nicotine, cannabis, or anything. Isn't that surprising? I was surprised when I saw this data. Now, that means 70% have used. Don't get me wrong. That's plenty. A lot have experimented or used or even progressed to problem status, but almost a third have never used. So when people say everybody's doing it, well, not exactly. Maybe everybody you know, but that's a cohort bias, right? About who you're hanging out with. It isn't everybody. And if you look at on the bottom, that text, when you look at current use, say past 30-day use, half of all high school seniors have used no substances in the past 30 days, don't have current use. And these trends are increasing over time. So that's good news. In some ways, certainly we're making cigarette smoking not cool anymore. Unfortunately, we haven't succeeded that way in cannabis use, but the trends are increasing towards increasing non-use or decreasing initiation. On the other hand, and this story is not told in this slide, there is an increase in severity in the group that are using. And so we have a divergence, just as use in general in average is decreasing. There's also a group of accumulating higher severity use. And we're going to be talking about that subgroup and the progression to loss of control, continued and frequent use, and addiction. Let's talk a bit about developmental vulnerability. This is the lifespan and the rates of past month use. So we've moved from lifetime use to past month use. That's more about current use. And this is for alcohol, tobacco, binge alcohol, any illicit drug use, and cannabis. And it's interesting, right? You can see on the left that the age span is expanded to the second decade of life only. And on the right, it's contracted to the rest of the lifespan. And the reason it's shown that way is because the left-hand side of the curve is where the action is, right? It's where the ascending limb of increasing use is. So I like to think about substance use disorder or addiction as a developmental problem of pediatric onset. Let me say that again. Addiction is a developmental problem of pediatric onset. It's a little bit over dramatic as a tagline, but it is true. And I wish that more broadly, from a policy point of view, we would adopt that stance of urgency. And if you think about any potentially chronic relapsing remitting condition, we know that early intervention before progression, before acceleration and crystallization of the most advanced malignant form of the disorder gets you better results. Of course, we're going to treat across the lifespan, but earlier is betterer. And yes, of course, people are using on the right-hand side, but when did they start, right? 95% of all people with a substance use disorder began under the age of 18. So that's why we have to be concerned. Here's another look at developmental vulnerability. This is rating risk of problem status of adults based on their age of first initiation. When did they first use? And looking at the rates based on whether they used before 14, between 15 and 17, or after 17. So it's a narrow 3 or 4 year window, but it's a lot of developmental water under the bridge, isn't it? And if you look across here, it confers a 2 to 8-fold increased risk if you initiated under 14 as opposed to over 17. Early initiation really matters. And if you look across the top at these light blue lines for people who initiated under 14, for these 3 substances, tobacco, alcohol, and cannabis, it confers about a 1/4, a 25% risk of problem status as an adult. Now, I don't want to exaggerate. That's not everybody. In fact, it's the minority. Most people do not progress to adult problem status, but 25% is plenty risk as far as I'm concerned. Here's another view. This is looking at the trajectory of the course from initiation to remission. How many years does it take, on average, to get from first use to stopping use as defined by a year of persistent abstinence in the community? And it's stratified, again, by age of initiation, under 15, 15 to 20, or 21 plus. And you can see that it takes a long time to get well, first of all. But secondly, if you initiate earlier, it takes longer to get well. Now, some people never get well, unfortunately. This can be a fatal illness in some people. But if you look across the median 50th percentile, younger initiation under 15 confers a 60% increase in the average time to remission. So that means delaying initiation beyond 18, beyond 21, as long as one can, confers benefit, confers improvement in prognosis. And that's an important prevention message to parents who might say, well, don't you worry, I'm going to teach them how to drink or smoke or whatever responsibly in my house under supervision so they don't go wild on their own. That is just false. This doesn't tell us that early initiation other than under parental supervision confers poor prognosis. It tells us that any initiation confers poor prognosis. Delay, delay, delay. What's inside the black box of adolescent vulnerability? How come it is that young people have more trouble? It's not that people couldn't have trouble as older adults, and of course some people do start as older adults, but most start in adolescence, and people who are exposed as adolescents, as we've seen, are at much higher risk. Well, that's because of all the things we know about maturation or immaturation in this very dynamic period of development. And young people have more impulsiveness and excitement seeking compared to other portions of the lifespan, more difficulty delaying gratification, more difficulty with cortical inhibitory control, with emotion regulation, with poorer executive function. And on the right is just one among zillions of examples of ways that we know from modern neuroscience that the brain is changing dynamically and rapidly and impactfully during the first decades of life. This is just a cartoon of changes in the brain, meaning decreases in the density of something called gray matter and increases in the density of something called white matter. But we don't need fancy scanners. We know just from psychology and looking at social change and spiritual change and physical change, all of these things are rapidly changing, and people aren't fully baked and ready to come out of the oven, if you will, till well into the third decade of life, in their mid-20s, when they are more mature in their executive function and their emotion regulation. And before that, they are prone and vulnerable to the temptations and the reinforcement of substances, both the positive reinforcement, that is jumping at the feel-good reward, and the negative reinforcement, jumping at the relief from negative emotions and negative experiences. Both of those are important and are highlighted and more impactful during these vulnerable developmental years. In our culture, temptation is everywhere, and adolescents are poorer at resisting temptation and delaying gratification. Here are just some graphics indicating that in our culture, and many others throughout the world, we have come to equate intoxication with the good life, with luxury, with living large, with being like your favorite pop and music and movie stars. That's a hard message for us to counter message. That's what we have to try to do, but we're swimming upstream. Okay, so that's our whirlwind take on epidemiology, scope of the problem, and development. Now let's talk about cannabis. What's the big deal anyway, right? It's just a plant. Well, here are some images, just in case you don't know some of this. The big graph in the center is an indication of the change over time, over several decades, of the concentration in plant cannabis of the active intoxicating ingredient, tetrahydrocannabinol, or THC, the same geniuses of plant breeding and biochemistry that increase the protein content in crop grains like miracle rice can breed increased THC concentrations. That's what the marketplace wants. we've seen 8 and 15-fold increases over several decades. And this is old data. It's only increased since then. Never mind edibles with even higher concentrations. Never mind wax extracts and dabs with either higher concentrations. Take a look at this in the warehouse. This is a reminder that we have come to scaled industrial production. This is not 3 or 4 scraggly plants in the backyard of your stoner friend next door. This is big league stuff. And wait until the big boys and girls on Wall Street get a hold of it. Right now, there are still federal restrictions on interstate commerce and financing and whatnot. That presumably is going to go away in 5 or 10 years, and then watch out. And up in the right-hand side is a photo I took in Amsterdam advertising strawberry cannabis ice cream. Who wouldn't want it on a hot summer day? But that's coming soon to a convenience store near you. Oh, don't worry, Dr. Fishman, we're not going to let anybody under 21 have access. Yeah, how's that working for you with beer? I know no adolescents can get beer in the local store, so no problem, right? And then here is the famous icon advocate of the cannabis nation, good old Snoop, right? Why do we care? What's the big deal? Well, it's not that it's immoral or that I'm advocating that, as you'll hear me talk, God eliminate this scourge from the face of the earth. No, this is a health problem, and we're concerned with vulnerable populations. I think the analogy is best to alcohol. A lot of people in this country, in fact, the majority of people in this country have alcohol experience, and most people do so occasionally, take it or leave it, without loss of control, without problem. No big deal if you have a glass of wine at dinner or a beer at the football game, right? That's none of my business. But vulnerable populations, today we're talking about youth, also those with psychiatric illness and also those with other substance use disorders, are particularly vulnerable. And the rates at which they progress from first initiation experimentation to acceleration of use is enriched and problematic. We're also concerned with the acute consequences of intoxication, like motor vehicle crashes. So driving buzzed, it's not maybe as bad as driving drunk, but why are those the only two choices? What about the third choice, driving sober? Would that be so terrible? We don't have time to look at the data, but there's increasing evidence about the psychiatric consequences of use of cannabis. It is not a benign intoxicant. Most people don't necessarily develop these, but a substantial minority do. We know that cannabis worsens depression and anxiety for a substantial group of people. Now, the patients may say, Doc, you don't understand. It's my medicine. It's the only thing that works. You can keep your stinking psychotherapy and your stinking pills. How are those two things compatible? Well, they can be, right? What patients or users recollect with nostalgic recall for peak blood levels is that brief time of intoxication and relief. Any intoxication, you feel a little less bad temporarily, but that's not sustainable. And what they don't know is that it's worser over time. The psychosis story is become very clear and replicated repeatedly throughout the world. The use of cannabis can both exacerbate pre-existing psychosis, maybe unlock vulnerability to psychosis, but also through toxic effects seemingly directly cause psychosis. The emerging evidence that, as I say, has been replicated, looks like we have between a 2 and 8-fold increase in the risk of developing first psychotic symptoms in cannabis users, and that's controlled for family history of schizophrenia in a dose-dependent fashion based on frequency of use and potency of use. In general, we think that use of cannabis increases the risk of developing schizophrenia, not just transient psychosis, but also persistent full-on schizophrenia by 4-fold. And with the increases in potency, that risk is increasing. And interesting data from Denmark suggests that the preventable percentage of cases of schizophrenia linked to cannabis use might be as high as 8%. Now, I don't want to exaggerate. I'm not saying one puff and you acquire schizophrenia, or that most cases of schizophrenia are linked to cannabis. Remember, I said maybe it's 8%, but that's still a lot, and those are preventable. And then lastly, cognitive impairment. This research is not as clear and needs to be replicated, but at least one well-done longitudinal study out of New Zealand shows a decline over 3 decades in regular adolescent-initiated users of cannabis of 8 IQ points over a couple of decades. That's half a standard deviation. I don't know about you, but I need all the points I can get. I can't afford to lose 8. And so I'm very worried, and you should be worried about this if in fact it's replicated and turns out to be true. But as I said before, the most important reason we make a fuss about cannabis and are concerned from a health messaging point of view is that some minority, but a substantial minority, especially of young people, don't just experiment, but continue to use, accelerate their use to more frequent regular use with loss of control, with psychosocial impairment and development of a cannabis use disorder and potentially progression to disordered use of other substances. So let's take a look at that. Here's some data that looks at time course to development of a diagnosis of cannabis use disorder from first initiation, right? So we're looking at less than 12 months from first initiation, 12 to 24 months, 24 to 36, more than 36. And we're looking at cannabis and alcohol for adolescents and young adults. And the take-home message here is that the rates of development of disorder within short periods of time, at least to me, are alarmingly high. 10% of adolescents develop a disorder within 1 year of first initiating, 20% within 3 years. And some estimates, although not in this study, show us that if you follow the line out into further years, that number might get as high as 40%. That's 3 to 4 times the rate of development of a disorder in initiates in adulthood. Again, reinforcing the point that this is a vulnerable period. We're not talking about what responsible adults do on Saturday night on their own time when it's none of my business. We're talking about young, vulnerable people who develop disorder at high rates. Again, not to exaggerate, it's not that most kids get in trouble, but enough do that it's alarming. Now, some people will be apologists. Come on, Dr. Fishman, stop being such an alarmist. Kids make mischief. Kids get into hijinks. They do all sorts of stuff. Yes, of course they do. But that doesn't mean that we shouldn't try to mitigate their risk. And surely, even if you are an apologist for occasional adolescent hijinks, experimentation, I hope most people wouldn't wave away daily adolescent cannabis use. So here's a glimpse at that, looking at current rates of daily cannabis use in 12th, 10th, and 8th graders. Just in crude numbers, 6% of 12th graders in the US are using cannabis daily. Holy moly. Thank goodness in 8th graders, it's only 1%. That's the good news. The bad news is 1% of 8th graders are using cannabis daily. Still quite a lot. And remember what I said about the divergence, even though we're seeing less initiation over time or more non-use over time, we are seeing increases in high severity use and development of severe disorder. And I just wanted to add the editorial, by the way, I don't have data for this, these red arrows on the bottom, this is my editorial, but to look at the historical time course of how this has increased over 3 decades, coincident with the cannabis access movement, with decreases in restriction, both in terms of the medical, so-called medical cannabis use movement and the recreational movement and legalization. And I worry that the trend is going to continue. Just one study from Australia looking at risks and harms associated with daily use in adolescents. In this cohort, daily use under the age of 17 was associated with persistent marijuana cannabis dependence into adulthood, with an odds ratio of 18, that is an 18-fold increase in risk. Maybe that's not so surprising. Past behavior predicts future behavior. A 3-fold increase in rates of high school dropout, an 8-fold increase in rates of progression to other drugs beyond cannabis, and a 7-fold increase in rates of non-fatal suicide attempts. And this is just a partial listing of some of the harms. So again, not trivial, not benign. And again, not to exaggerate, it isn't everybody, but it's enough of a risk that all of us as professionals, as parents, as teachers, as policymakers need to be concerned. All right, so there's the whirlwind on cannabis. Now let's talk about what we should do about it. First of all, this is what we should not be doing about it. Here are some old-fashioned scare tactics. It's the devil's weed, one puff and you'll kill your grandmother. That's not helpful. It's not true. Young people don't respond well to scare stories, even when they're true. If you tell young people not to smoke cigarettes because they might get lung cancer in 40 years, that's true, but it's not going to change their behavior. What's going to change their behavior? Don't smoke cigarettes because it'll make your breath stink and no one will want to kiss you today. Oh, now I'm listening. But in any case, we need to avoid these historical exaggerations to establish credibility. If you've never, we don't have time for me to show the video, but if you've never seen the old black and white movie from the 30s, Reefer Madness, it's a hoot. I've got the YouTube link here, or you can just Google it. It's funny. And this is just the trailer, so you don't have to watch all hour and a half of it. 3 minutes is plenty, but it's mayhem and debauchery and insanity and murder and suicide and not helpful. We can, in calm, health-oriented ways, give a message that is digestible. One way that we have learned to talk about substances in general, cannabis, alcohol, and nicotine being the most common in young people, is through this paradigm of SBIRT. SBIRT stands for screening, brief intervention, and referral to treatment. And it's an approach where generalists who aren't subspecialists like me in addiction care can incorporate a graded dimensional approach to addressing substance use in brief amounts of time within the context of the youth-facing professional work they're already doing. Examples where it's been most studied include pediatrics and family medicine, but it's also been proven and adopted in mental health situations. You're seeing kids anyway, they're presenting for mental health problems. Are they using, are they not? And what can you do about it in the setting of non-specialty services where you're already building therapeutic alliance? First of all, it starts with universal screening. Ask everybody, make it routine. It's what we do. For low use or no use, praising their current progress. Attaboy, attagirl, keep it up. For those reporting recent initiation, low levels of use, recent experimental use, but not use disorder and not impairment, giving them brief advice about what their choices are, what the risks and benefits are, what they might do to change the trajectory to avoid future harm. For those that are developing mild impairment and mild symptoms, developing the technology, not the technology, the comfort and the ability to be able to do brief motivational interventions. By brief, I mean 5 minutes, 10 minutes, 15 minutes, to be able to talk through how it might be affecting your goals and what you might do to avoid future use and cut down and quit. And then identifying people, young people who have moderate or severe or non-responding problems who do need referral to subspecialty care, and establishing those relationships for referral within the resources in your community. Here's a case, just as an example, a 14-year-old boy that you might see in your mental health practice, and you're screening and asking about substance use. Not, have you ever used substances, but how often have you used these substances, right? Because you assume many people have, you saw the numbers, and you just want to get a matter-of-fact reporting. And he tells you he's done some drinking at parties, he's used cannabis a few times, it's no big deal. Why are you asking? Overall, this is a high-functioning young man. His parents are unaware of his use. He hasn't talked much about it. And when you ask him more about it, like, what's it do for you, pros and cons, he says he likes it. It's kind of fun. Everybody's doing it. On further exploration, he says, yeah, but at a party last weekend, he did get a little loud, more than he meant to, and he felt embarrassed. And, you know, weed does make me feel a little weird. I can't exactly explain it. I'm not sure I love it, but I kind of love it, but I don't kind of love it. This is an opportunity for a brief intervention, right? This is a guy who has started to experiment and starting to progress in his use. How can you talk to this person about those experiences and get him to be honest, to get him to feel comfortable as you're continuing your therapeutic alliance, to talk about the pros and cons and connect the dots between the goals that he sees, maybe his mental health goals, maybe other goals, and whether there's the possibility that continuing or progressing use will be problematic. Doesn't have to be a big deal. It's a conversation, and it's a longitudinal conversation. Important to know the concept of the stages of change. You guys certainly know that, the idea that people don't come to your door, knocking on your door saying, you know, I had an epiphany, I've got a problem with loss of control of my cannabis use, and I'm ready to do everything you say to stop. No. They come in pre-contemplation or even pre-contemplation. It's no big deal. And so we need to focus explicitly on the idea that motivational enhancement work, motivational interviewing, meeting them where they are, trying to work with them to progress through these stages of change, explicitly knowing that they're not going to see it that way at the outset. I want to give you some language that I sometimes use in initial motivational intervention. Everybody's got to have their own voice, their own language. You tailor it to the person in front of you. But it's just maybe helpful to hear how I have some of these conversations. When you talk to a kid and say, you know, it sounds to me after you've done your initial interview, your initial evaluation, it sounds to me like you've got a problem with cannabis use. And they say, nah, it's no problem. I'm fine. I'm no different, et cetera, et cetera. So one of the first things to do is to try, instead of going up the middle and finger wagging and scolding and saying, well, I'm the doctor, I know best, you better, to take the defensiveness out of it. And instead of pushing, yes, you have a problem, yes, you have a problem, back up a little bit and say, well, all right, we'll agree to disagree. I use that phrase a lot. We'll agree to disagree. You say you don't have a problem, but surely you know somebody else who has a problem. Somebody who smokes too much, somebody who's been in trouble with cannabis, or it could be alcohol or whatever, but we're talking about cannabis. And is it your older brother? Is it your girlfriend's cousin? Is it, you know, whatever. And tell me why you think that person smokes too much, and tell me why you think they're in trouble, and tell me why you aren't like that person and wouldn't go that far. And you see what I'm doing here is, even though I may not be on the same page, maybe I'm at least in the same book, establishing that there is such a thing as too much, establishing that there are harms and potential psychosocial impairment associated with cannabis, and then we can progress from there. Do you know why I or your parents might think it's a problem? I know you don't agree with me, that's fine, but why would we say such a stupid thing? And that's an important developmental exercise, to get a kid to step outside themselves and try to adopt a different perspective and walk a mile in somebody else's shoes. What are the pros and cons for you? And you start with pros. Why would I start with pros? Because people wouldn't use substances if they weren't good in some way. So acknowledge that. You get credibility points. You help build an alliance. You appreciate that there might be an upside. That's fine. And then, now that I've understood what you like about it, what's bad about it? Nothing's bad about it. I already told you that. All right. Again, we agree to disagree. But let's just say that in some alternate strand of the multiverse, you did progress and used in some other way, or used more, or had a problem. What could that potentially look like? Let's see if we can scout that out. You say now, for example, you only smoke with your friends. Well, what if you started smoking alone? You say now you only smoke on the weekends. What if you were smoking during the weekday? You say now you only smoke after your homework's done to relax. What if you did it before you did your homework? What if you were smoking before school or at school? Go there. And now you see what I'm doing is, maybe I'm still not on the same page, but maybe I'm in the same chapter, having the discourse about what constitutes too much, but making it personal and laying the groundwork to connect the dots, so that when they come back next week, 2 weeks, next month, whatever, I look at my notes and I say, you said that you didn't think it was a good idea to smoke on the weekdays, but you just told me about the party you went to on Wednesday. What's up with that? I've changed my mind, Dr. Fishman. Wednesdays are fine. Well, and that's a way of having a longitudinal conversation over time, looking at lines in the sand that somebody swore they would never cross, but now maybe is crossing. And can we look in the rearview mirror at a succession of such lines and maybe connect the dots? But the most important thing here is, listen, I'm so proud and pleased that you've been honest with me, right? You don't want the kid to say, okay, Dr. Fishman, I'll never smoke again. Cannabis is terrible, because that's not helpful and it's not true. I value your opinion. I want you to push back. We can disagree civilly, but as I get to know you, I want you to continue to come back and talk about this and look at it together. And it's a marathon, not a sprint. Here are some of the other kinds of language that you might use. Listen, intoxication can impair judgment, maybe not all the time, but sometimes. Have you ever done anything that you've ever regretted? Yeah, of course, everybody's done that. Well, did you notice you were drinking or smoking on that day? That has nothing to do with it. All right, well, listen, people who smoke cannabis and you're around them, are they into other kinds of trouble that might rub off on you? Are they doing illegal things? Do they have other drugs? Are they getting in trouble? Are they skipping school? Whatever. Is that the crowd you want to be with? You can sometimes use the metaphor of teen brains are easily bruised. You haven't built up your full force field. Substances are a biological hazard that, as a sledgehammer, hijack the brain's natural reward system. Some kids will buy that. Other kids will glaze over and not care. Maybe a little is okay, but is what you're doing a little? Sounds like a lot to me. I'm not saying it's never okay, but maybe it's not right for you now. Maybe you should wait till you're older, 18, 21, I don't know. But your force field's not quite powered up. Later, it's not going anywhere. And if it's that good and that important to you, that you're totally ignoring what your doctor and your teacher and your parents and your girlfriend are fussing at you about, maybe it has its hooks into you more than you know. What about that? And you said you could quit anytime. You haven't even tried. Is it got its hooks into you more than you say? Anyway, these are different messaging. Sometimes they work, sometimes they don't. There's no one size fits all, but it's good to get comfortable trying out some of these different lines. Another technique that we use a lot is the readiness ruler. How important is it for you to change in terms of any risk behavior, but we're talking now about substance behavior, and how confident are you that you could make such a change? Say, for example, cut down on your cannabis use, or stop using on the weekdays and limit it to weekends only, or whatever the goal is. And okay, you say your confidence is a 5. That's great. That's terrific that it's more than a 4. What do you think keeps it from being a 6? And how could it get to a 6? And so that establishes that conversation. There's a bunch of adolescent substance use CBT manuals. They're very similar if you've used CBT for depression or for anxiety or for PTSD. Many overlaps as you look at this chapter table of contents heading. Some of them are specific to substances like relapse prevention and refusal skills, but others are about emotion regulation, problem solving, communication skills, anger awareness. I'll show you some examples and where you can get some of those manuals. There's another technique we use that was one of the headings in the table of contents we call the relapse chain analysis. It's one of my favorites. And it's a way of looking at the antecedents of use. Because you ask somebody who says, yeah, I used. All right, why did you use? They don't know why. I just used. A blunt suddenly appeared miraculously in my mouth. Who knows how it got there, right? So never mind why. Let's talk about the what and the how. And so it's a way of going backwards. I call it the rewind video slow-mo, breaking it down into tiny steps. What did you do? What'd you do before that? What'd you do before that? What'd you do before that? And now we're looking at a screenplay, at a script. And each step along the way matters. Eventually, you get to the point that you're in the room with a bunch of your friends and somebody lights up. That's hard to turn back from. No, thank you. Never mind. I don't do that anymore. That's asking a lot of a 15-year-old. Instead, what are the points before the point of no return? And let's rewrite the script. You know, I don't know if you're a horror movie fan, but sometimes the audience is watching a horror movie and the protagonist is going to go down the basement steps and it's dark down there. And we, the audience, know the guy with the chainsaw is down there hiding. And we're thinking, don't go down there. This is the similar exercise. How do you convey the urgency of how can you not go down the basement steps, but upstream, 10 steps upstream before it's too late? So it's a nice kind of exercise, and you can practice doing it with young people. As I said, here's some examples of some of these manuals. There's many more. Some are available for free. Check them out. You'll have the resources here. And then ending with this treatment section with a note of optimism. This is similar kind of graph to the survival curves I showed you, making the point that the earlier they start, the longer they use and the slower they are to remission. This is turning it on its head. The earlier we intervene, the quicker they get to remission. So this is time from first use to remission by 1 year of abstinence in the community, but stratified not by age of initiation, but stratified by time from first use to first treatment episode. 0 to 9 years to first treatment, 10 to 19 years to first treatment, 20 or more years to first treatment. And if you look again along the 50th percentile median, early intervention confers almost a 60% improvement in time to remission. So earlier start, worserer. Earlier treatment, betterer. All right. Obviously, there's much more to treatment than that, but there's the whirlwind. Now, I want to take you on a super quick tour of some specific issues in dual diagnosis or co-occurring psychiatric disorders. Remember the lifespan I showed you with where the incidence of substance use increases in the left-hand side of the first 2 decades of life. This is that similar data, but with these 2 arrows superimposed showing that a half of all psychiatric disorders have their onset before age 15, and 3/4 of psychiatric disorders have their onset before age 24. So of course there's overlap. Of course there's co-occurrence. Even if they weren't causally related to each other, which they are, just the coincidence in age confers risk. We're not surprised at dual diagnosis or polydiagnosis. When was the last time you saw any young person in your practice that had 1 diagnosis, not 7, right? And substance use is a frequent occurrence. Here's another look at that. If we look at adolescence, past year major depressive episode, is strongly associated with the initiation of alcohol and initiation of other substances, between a 2 and a 3-fold increase if you had major depression versus if you didn't. This data doesn't tell us which comes first, chicken or egg, but it does show us they're reciprocally intertwined. Here's some treatment data from our treatment center that we did actually 3 decades ago, looking at admitting adolescents to specialty residential care for high severity substance use disorders. We're looking at the number of days used in the past 90 days at baseline is 90-ish%. That's how you get into residential treatment. You're a heavy user. Then we're looking at treatment progress over a year. So these patients spend 3 or 4 weeks in treatment. They get out, and at 3 months, they've substantially decreased their substance use, not to zero, unfortunately. We're not curing anybody, but much decrease. Then there's this usual checkmark attenuation of the treatment effect. They're back in the community. They're not going to continue in care. They're back among their using peers. But even at 12 months, even though some of them are using again and some have relapsed, there's still substantial reduction from initial use. So first message is treatment works, but then look at the difference between the two groups. These are those with low baseline Beck Depression Inventory, BDI, or higher baseline BDI. And it makes the point that those with depressive symptoms, they get better, but they don't get as better as those without depression. So at all follow-up time points, people with baseline depressive symptoms, adolescents with baseline depressive symptoms, have higher rates of relapse, higher rates of use, reminding us that we need to pay attention to co-occurring disorders and specifically treat them in concert with the substance use disorder. Here's the Gary Larson psychiatrist looking at the substance-involved teen and saying, just plain nuts? No, we can do better than that. Now, as I said before, we often don't know which comes first, chicken or egg. We ask a parent, when did they first have trouble with their moods? Oh, I don't know, 12, 13, 14. When did they first start getting into alcohol, nicotine, or cannabis? Oh, I don't know, 12, 13, 14. It's often a jumble. If you can establish chronological precedence, that's helpful, but usually you can't. So then this becomes less of a relevant question for the majority of patients. And instead, we want to focus on integrated, concurrent treatment of both sets of disorders. Not serial, one then the other, because then people won't come back, but both together. The good news is that standard psychiatric psychotherapy and standard psychiatric medications work fine, not as well, but work in young people with substance use disorder. Don't be shy. You don't have to wait for them to be abstinent. You want to encourage them to be abstinent, of course, to quit, to cut down and quit, but don't wait, don't postpone. You want to have a longitudinal view with a view towards engagement over the long term. You want to have an active, even assertive engagement process. We're not waiting for them to come to us, but we're reaching out to them as much as you have the resources to do. This is a marathon, not a sprint. We don't expect sudden cure and an epiphany and a lightning bolt with the scales falling from their eyes. It's an incremental progress with 3 steps forward and 2 steps back. That's okay. You have to educate the parents again about that because that's frustrating to them, but it is reality. And don't expect that insight is the first step. Insight comes later. That is not typically the way we get behavior change in young people, is through insight. We hope for internal motivation, but usually we start with extrinsic sources of persuasion, leverage, and motivation. I don't have time, but there's good research that shows us that this integrated co-occurring treatment model is what's effective. For example, studies in both depression and ADHD in young people with active substance use, giving them appropriate medications, showing that not only are those medicines safe, not only are they effective, but that improvements in symptoms, both the substance use symptoms and the depressive symptoms, tend to occur together. And to expect improvement in one set of symptoms without the other is to set yourself up for failure, and is not usually what happens. If people are going to get better, they're going to get better in their depression. If people are going to get better in their substance use, they're going to get better in their depression. If they're going to get better in their depression, they're going to get better in their substance use. You can't just treat the substance use and expect the depression to melt away. You can't just treat the depression and anxiety and expect the substance use to melt away. You got to do both. Here's another case. You're seeing a 15-year-old girl brought by her parents who describes some social withdrawal, some irritability, gradual change in peer group, some academic decline in what was previously a high-achieving student. They have no knowledge of her substance use. She tells you, yes, I'm not feeling myself, I'm worried, I'm irritable, I notice my concentration's not right, my sleep is not what it ought to be. She kind of agrees with her parents' request for addressing maybe a problem in the depression realm. Everybody's above board with that. But when she's alone with you, while you screen for substance use, she says, yes, she has done a little experimentation with cannabis. She has had beer. Not recently, nothing like that, doctor. That's in the past. As you get to know her and further exploration, she says, well, actually, I do smoke on the weekends, but it has nothing to do with my depression and it's no big deal. So this is an opportunity to engage her where she is, because she and her family recognize that the depression is a problem and she's treatment seeking in that realm. She thinks you're full of baloney about the problem of substance use, but you have an entree in that she wants to feel better in her depressive symptoms. And that's an arena in which she might be open to connecting the dots, in which you teach her over time. It's not going to be day one epiphany, but in which you teach her over time that cannabis ain't helping her depression any. And the medicines and the psychotherapy are not going to work as well unless she's able to cut down and quit. So you see, you have a way of using your superpower that you already know how to use, depression treatment, to start to leak into and spread over the additional newly acquired superpower of making substance use on the table and an area in which you can make progress. All right. I wish we had more time and we could talk all day about that, but we got to keep moving. So let's talk about opioids. As I say, these will be generally uncommon in a general practice setting, but not zero. And despite it being uncommon compared to other times in the lifespan, it is still very dangerous. Just want to put it in context here. And if you get nothing else from the OUD part of this, here it all is. We want to think of OUD not as a separate illness, as a separate entity. We want to think about opioid use disorder as part and parcel of the progression of the broader construct of SUD, but it's an advanced, more malignant form. Again, like other earlier forms of SUD, it usually begins in youth. Adolescents and young adults are extremely vulnerable. We've been over that. Going to talk about one of the great tools we have, which are the medications for OUD. Particularly in young people, we use buprenorphine and extended release naltrexone, but unfortunately, not everybody's gotten the memo about their effectiveness, and dissemination and uptake is poor. There's problems with treatment capacity, there's problems with misinformation and prejudice. I'm going to say again and again, we need to do a better job with that. But we should be disseminating it, and medication-forward approaches to youth OUD ought to become the standard of care if they aren't already. Unfortunately, young people, although they respond to these medicines, they don't respond as well as older adults throughout the lifespan. That's probably because of the same developmental vulnerabilities that get them in trouble in the first place. And then I'm going to transition to talking about some developmentally informed approaches, particularly family involvement. So just some more scope of the problem data, looking at increases in fatal adolescent overdoses, they are still rare compared to overdoses later in the lifespan, where we've had 100,000 substance overdose deaths, 80,000 of them being OUD, fentanyl related. We had a decrease last year to 85,000 deaths in the US. Whoever thought we'd be celebrating only 85,000 deaths? But I guess any progress is progress. The important thing here is that although the numbers, the absolute numbers for adolescents are small, the rate of increase is quite alarming. So it's something we have to pay attention to. Here's just some pictures. You probably know this, that fentanyl and other fentanyl analogs like carfentanil and others are 50 to 100 times more potent than heroin. That's the problem. It's very hard to calculate dose and an easy thing to miscalculate and have a fatal overdose. The way most young people are using these days is by crushing and sniffing or smoking counterfeit street pills that they think of as Percocet or counterfeit Xanax or counterfeit Adderall. And on the bottom right, you have a picture of Percocets, or in Spanish, Perco, or M30s, and they look to the untrained eye, even to the trained eye, just like pharmaceutical pain medicines, oxycodone, Percocet, but they're not. They're all fentanyl all the time, and that's what's on the street, period. It's not Percocet, it's not heroin, it's fentanyl, and it's super easy either for the naive early user or for the experienced user to take just a little too much, and because of its potency, to have a fatal overdose. A word for prevention, again, linking OUD to the broad arc of other SUDs. Most youth who initiate opioids have had a problem with other substances before that. That is, they didn't just stumble on an evil orthopedist who gave them pain medicine. They had already had progression and loss of control over the use of some other substance, pre-opioid substances, which for youth are, as I keep saying, nicotine, alcohol, cannabis. We've said earlier onset is associated with worse outcomes, but earlier intervention is associated with better outcomes. We've said that opioid addiction is an advanced stage to a more malignant, more accelerated subtype. So the prevention message is that if only we would do more intervention in earlier pre-opioid substance use and substance use disorder, nicotine, alcohol, and cannabis, that in itself would be opioid overdose prevention, right? So we need to get that public health messaging out because, as you well know, we have this public messaging and decrease in restrictions and increase in access and a public misconception, as far as I'm concerned, that, oh, cannabis is no big deal. Yeah, kids drink. What's the big deal? It is a big deal. Talk about medicines for a second. We don't have time to talk about the pharmacology and how they're utilized, but we know that they are the standard of care for opioid addiction throughout the lifespan. This is methadone, not so much for kids, buprenorphine, both in daily sublingual form and in monthly injectable form, and naltrexone in a monthly injectable form. We don't have as much evidence and research on safety and effectiveness in young people as we do across the lifespan, but we have enough to be clear that there's no safety problem conferred by chronological age. I'm not saying these medicines don't have side effects. Even Tylenol can have a side effect, but not special or additional side effects for younger age. The outcomes are very good. These are life-saving medicines. They should be used as soon as a person has OUD. There's no reason to wait. The outcomes aren't as good as for older adults, but they're still far better than without medicines. How long should I use them? Dr. Fishman, I don't want to take these medicines, then I'll have to take them all my life. I never said anything about all your life. Let's just get you on the medicines and stabilize, and then we can talk about getting you off. But really, how long? I don't know. Give me a year. Where did that come from? It's more than a day, less than a lifetime. It's enough time to stabilize, but it may not be long enough, and we just don't really know. But longer is better, and there's no evidence for an arbitrary preordained time limitation. There's also no evidence for making these medications second line. That is a fail first approach in which non-medication treatments are where you start, and then only people who fail that get to medication treatment. No. There's no evidence for non-medication treatment of opioid use disorder in young people. There's all the evidence for medication treatment of OUD in young people. And besides, what does failing treatment for OUD mean? It could mean a fatal overdose. We don't want to wait for that. Now, I'm not saying by any means that medications are the only treatment. I want to be very clear. I'm advocating and would always advocate a multi-component, multimodal, holistic spectrum or matrix of treatment with medications and counseling and therapy and self-help and family involvement and lots of these components, and co-occurring treatment and lots of these components. But because the medications for opioids, I don't have medications for cannabis, but the medications for opioids are so impactful and effective that we should lead with a medication forward approach, and we should not let the perfect be the enemy of the good. And although we encourage all of that holistic treatment, start with the medicines and don't deny people access to the medicines, even if they are knuckleheads and refuse the other good things you're offering. This is not just my opinion. This is the American Academy of Pediatrics, the American Society of Addiction Medicine, the American Academy of Child and Adolescent Psychiatry, et cetera, et cetera, et cetera. But unfortunately, if only it were that easy, right? We're not just going to be able to put more buprenorphine in the water and expect all to be good. So I want to talk now about some issues where we aspire to a better developmentally informed approach. And I want to focus on some work that I and my group have done with a particular intervention that emphasizes family involvement. And I do this with a bunch of fancy pants grant funding, but you don't need that. It's the general principle that families are huge, families are impactful, and they are an underutilized element in general in our treatment. There's lots of reasons for that. Young people have a normative pushback against their sense of parents being overly restrictive. I'm all grown up. You can't tell me what to do. Mom, what do you know about this? Clinicians may feel uncomfortable about involving families. It's hard enough just taking care of the kid in front of you. Now I need 7 more stakeholders. Besides, I'm not a trained family therapist. Well, I'm not saying you need to be a formally trained family therapist in advanced high fidelity structural family therapy. I'm only talking about layering on some principles of including families who are central to these young people's lives anyway. You might as well make the most of it. We tend, I believe, to be over rigid in our concern with confidentiality. And confidentiality is super important, but I think we overdo it. And there are ways where we should be thinking about how do we get to yes? How do we make it routine that families are involved, that we set the goals and the landmarks and the rules for communication and train and coach the families on how to contribute in a positive way instead of the nagging punitive approach that they might have when we first meet them. So what should we do about confidentiality, right? Should we follow rigid limitations on disclosure? I can't talk to anybody. Should we go behind a patient's back and make unilateral and surreptitious disclosures? No, neither of those. In between, we should be getting to yes, winning consent over time, and making it part of our natural, routine, normative treatment process. I talk to a young person, I talk to a person at any age and say, I want to talk to your family. What should I say when they say, you can't talk to my family? I know my rights. Should I say, okay, I won't talk to your family? Or should I say, oh yeah, watch me? Or better, should I say, well, they're going to call. What do you want me to say? That you've forbidden me from talking to you? How's that going to go over? Or even better, what about we talk to them together? What about you and I rehearse how it's going to go? What about you tell me what's off limits, but I try to convince you what's really important and how you can earn mom points and dad points? And isn't it going to be better coming from you? Because you're going to get busted anyway, and it's better if you're negotiating from a position of strength, et cetera, et cetera. This is what we do. What's the worst thing can happen? We can invite them in. If you want to fire them and send them back out, let's talk about that. Wouldn't you rather have their help? They don't help me. They just nag me and yell at me and they want to kick me out. Well, how's that going for you? What about if I could run interference and give them a better model? And that's something nice, that you can model in front of mom or dad. Mrs. Jones, when you said such and such, do you think there's a nicer way you could say that, or a way that you'd win more flies with honey than with that? You talk that way to my mom? Dang. And that gets you some points. What if I help you get them to back off some? These are all ways of doing that. And then we've got to do the family coaching. Families, when they first present, they're up to their ears in alligators. They don't know how to do this. They've tried everything. Nothing works. They've heard it all before. I'm not the first person to give them advice. So you got to be patient. You got to emphasize with their distress. And then you try to, in small digestible messages, coach them on how to be more consistent, how to not waver between don't ask, don't tell, and decapitation as strategies. Somewhere in the middle, pick your battles, know your leverage. You got to give to get. You have more juice than you realize, but you got to focus it. Keep your eyes on the prize. Don't be defeated by every little slip. 3 steps forward, 2 steps backward is better than the way it's going now. That's okay. Part of what we've developed is an approach to collaborative treatment planning and collaborative family sessions, where we bring a kid and a designated treatment significant other. We ask them, pick somebody. It's typically a parent, but if it's not a parent, it could be whatever, boyfriend, girlfriend, coach, mentor. And let's work as partners. And let's teach them about the medicines. Let's teach them about how the program is going to work. Let's teach them about scheduling. And let's give them a particular role. And the role that we emphasize, because it's more digestible, is simple and concrete. Let's focus on medication adherence. Again, I'm not saying that's the only goal. I'm not even saying it's the most important goal, but it's understandable. Because people aren't born knowing what we do in mental health therapy and in substance use disorder group therapy. What does you people do? You sit around and hold hands and sing Kumbaya, and what's the secret handshake? And no. I want you to think about standard healthcare service utilization models like we do in all other medical subspecialties. If your family is struggling with dealing with the medical system, taking their medicine, getting to appointments, whatevs, you help them. If granny can't take her pills, you put them all in the pill box for her. If people can't get to appointments, you take them. But with substance use and other mental health issues, it's too secret, it's too shameful, it's in the closet. So no, let's make it explicit. What can your role be for helping with getting to appointments, with helping with taking medicines, with tracking whether they got their shot, et cetera? And then let's have a backup plan. Why do I need a backup plan? I'm in, I'm done, I'm finished, I quit. Yeah, okay, but just in case, let's have a backup and a backup and a backup. Young person, what would you like me to do if I have to call the cavalry? What would you like your mom to do if things go askew? Mom and your family, how would you want to handle a crisis? I hope it never happens, but if it does, let's plan now and let's write it down and get signatures. Not that it's legally binding, of course, but it's a ritual. We call our intervention, which we've been developing over about a decade with some fancy pants research grants, YOURS, Youth Opioid Recovery Support. It has these elements: assertive outreach, that is reaching out to people, texting them, not waiting for them to come in, involving families, as I've been talking about. and low barrier access. We started with home delivery of injectable medications, but we found that people sometimes like to be Ubered or lifted in or come to clinic or home delivery, but whatever. And we've also adopted an evidence-based treatment called contingency management or motivational incentives, in which we give rewards for adherence to medications. And I'm looking at the time, and I want us to be able to have some time for discussion. So I'm just going to show you really quickly that we've done some studies, and this kind of intervention compared to usual care is pretty effective. So here's an outcome in which over 6 months, people in the Yours intervention in 2 of the studies we've done got far more doses of monthly injectable or long-acting injectable or extended release medications, either injectable naltrexone or injectable buprenorphine, than folks in usual care. So we're on to something. There's room for improvement, and I'm not going to show you the relapse rates, but the relapse rates are vastly improved over treatment as usual, but they still have lots to be desired. So we're still tinkering, we're still working on it. And to wrap everything up, well, one more point about that. I'm not saying that you guys need to be opioid use disorder specialists, or that you're necessarily going to want to put up a sign in your mental health clinics that say buprenorphine prescribed here. If you do, that's great. But even if you don't want to do the ultra high end, the principles that I've been talking about in terms of the SBIRT approach, in terms of the motivational approaches, in terms of family involvement, I think are all things you can import into care where you're already doing developmentally tailored, youth welcoming treatment. You guys are the experts. You've got the kids there. It's just about expanding a little bit to also explicitly focus on substances, which are already clearly part of the problem in many of the young people. So we have this toolbox of highly effective interventions across these different substances, but unfortunately, there's a low level of adoption and utilization. Adolescent substance use is not no big deal. It is a big deal, and we need to do better with developmentally informed interventions. And on the right, I got a picture of what I would have hoped would have been someday an aspirational miracle cure, right? If only we could do brain transplants and get these kids beyond. But in some sense, we can, right? If you keep them alive long enough, maturation happens. They grow up. And so they get their own brain transplants, but you got to encourage them and nurture them and coach them and their families along. So I'm going to quit, and we have a few minutes for some discussion and questions. I hope that was helpful.
Yes, thank you so much, Dr. Fishman. Really appreciated. And clearly there is a need for all of this in terms of topic, because there were a lot of comments coming in from individuals either resonating with some of the data that you shared in the work that they see, for example, really younger age ranges of children utilizing even vapes, right? And folks seeing carts and things along those lines. So let's see if we can start off here with a question, a clarifying question. I may have understood, but is methadone contraindicated for youth with MOUD? If so, why?
Not contraindicated, just not widely used and widely studied. And in large part, that has been an artifact not of the efficacy or effectiveness of the medication molecule itself, but an artifact of the regulatory delivery system in which we have rolled out methadone since its initial adoption in the 1960s. As you may know, it's available not in general medical settings or even in general mental health settings or even in general SUD settings, but only in specially state and federally licensed, typically isolated opioid treatment programs where there are so many barriers, and typically it is not delivered in a developmentally targeted, youth-friendly way. I can conceive of constructing a youth-specific methadone program. It's just that they don't exist. On the other hand, buprenorphine, which is by regulation and practice allowed in any healthcare system, is much easier just to import into places where kids are already treated in a developmentally appropriate and welcoming way.
Great, thank you. So we are also seeing some folks who are saying that they're seeing an increase in young children ending up in the ER after consuming edibles. And I know you mentioned this a little bit. It seems to be minimized by the family. So wondering, as a result of that, they sometimes decline treatment. Any thoughts on how to address this issue that folks are seeing?
Yeah, it's an important issue. You know, there is, for most youth, the problem is intentional use of the substances we've been talking about in search of its intoxicating effect. But you raise the issue of accidental exposure. Edibles and gummies look like candy and are sweet. And so if you leave them lying around, or if your toddler or preteen sneaks into your cookie jar, they're at risk of a significant toxic exposure. So people, just like when you warn them to lock up your medicines, we don't want them to allow the risk of vulnerable toddlers, young people, whoever, getting into their stash. So people need to be educated and told, and it is not a trivial exposure. And the concentration of THC in some of these edibles is very high.
Yeah, no, I appreciate you mentioning the accidental exposure. Thank you. There was a question around your thoughts around harm reduction here.
Oh, wow. Well, we could spend the next week on this. And it depends on what you mean by harm reduction. It's not a phrase I use because if you ask 4 experts, it means 7 different things. And it's become politically charged. It is a phrase that we use in SUD, and I'm not sure why. I guess I understand historically that there have been restrictions on incrementalist approaches in SUD, that it's all or nothing. But I like instead to think about what many people categorize as a harm reduction as just the way we do medicine in every other field and in any treatment of any chronic remitting relapsing condition, hypertension, depression, diabetes, arthritis, et cetera. That is to say, we don't expect surgical cure on day one. We don't expect just bifurcating binary categorical treatment outcomes. Treatment outcomes are dimensional, are gradualistic, are incremental, and that's the name of the game. So if I treat your diabetes and get your hemoglobin A1C from 12 to 9, that's praiseworthy. And I cheerlead for that. And I don't fire you when you eat a candy bar, and you shouldn't. But I'm not done because you got to 9. I'm still encouraging you and cheerleading you to get it below 6 and to 5. And so everybody deserves to be well and get all the way better. So my problem with harm reduction approaches is that, yes, we need to be incremental. That's just good medical care. We don't fire people for being ill. We encourage them to continue treatment. But it's not okay to say the best you can do is to safely inject. No, we don't want to encourage a hospice approach to substance use treatment. Everybody can get better. And I can't tell in advance, unlike oncology, where I might know that somebody with esophageal cancer only has 6 months to live, and I want to help them die with dignity and comfort. That is no way to treat an addiction patient. Anyway, there's my brief rant. If you want to stay for the next hour and a half, we can continue talking about it.
Yeah, thank you so much. I appreciate your thoughts on that. And let's see if we can squeeze one more question in. So clearly we know that substance use affects many populations, communities. Do you have any data or experience with adolescents with developmental disabilities or neurodiverse youth and substance use disorder?
Yeah, it's a great question. I have a little bit of clinical experience, but not much. And there's very little written on it. And it is a population that is at high risk, maybe higher risk than the average person with other co-occurring disorders. And we know very little about specifically tailored and integrated treatments. So much, much more work needs to be done. It's a great question, and I wish I knew more.
Great, thank you. Yeah, so for any folks in the audience that maybe have access to conducting research or whatnot, clearly seems to be an area that we need to follow up on. All right, so I think you spoke a little bit about, the family system. Wondering if there's anything that you wanted to add around when the concern to exposure is or has been the family system of the child. So I know you spoke a little bit
Yeah,
about
that's a great question. Lots of families are pre-contemplative and pre-contemplative.
Mm.
And when a family presents to try to get a kid help, the last thing you want to do is push them away by starting to lecture them about their use. And I think you've got a problem. What are you talking about? That's none of your business. You don't know me. I didn't come here for me. I came here for little Johnny. So unless you actually know something and have a relationship with the person or think you can make a relationship and get them to accept help, I do what I call a universal precautions approach, which is to say, listen, there are some families, and I'm just meeting you, I don't know what you're like, but there are some families that use alcohol or other substances, nicotine, cannabis, whatever, recreationally. It's legal. I get that. Most people don't have a problem. I don't know if that's true in your household. But you know, we've learned that when we're trying to work with kids and getting them to cut down or quit, they're mimics, aren't they? And they do what you do more than what they say, than what you say. So do me a favor, and I know it's a lot to ask, but while we're helping your kid, little Johnny, I advise parents to adopt a substance-free household. And I know it's a big burden, and I'm not saying forever, but for now, it really helps them, even though it's a burden to you. And if you're good, at least if you're going to do it, don't let them see you or know about it. And sometimes that's digestible and it helps. And sometimes it gets me punched in the nose, but it's something to try.
Great. Yeah, no, appreciate that. So I don't know if you can bring up the slides, Dr. Fishman. If not, no worries. There was a question around some of the references, but for folks, the slides will be posted in the next 3 to 4 days. There are some selected references in the slide deck. There are also some resources with hyperlinks at the end of the slide deck. And I am mindful of time, so I do just invite folks to our upcoming events. We have a good number of events next week on serious emotional disturbance, a panel discussion on working with queer youth and families, and strategies for recruiting youth peer advocates. Lastly, you will be getting, or if not already, a pop-up for a survey. If not, there should be a link in your chat box. Again, I encourage you to fill that out as it helps to inform all our future offerings. I do want to say a big thank you to our presenter, Dr. Mark Fishman. Clearly, there is a lot of interest and need in this area for our youth today. So thank you so much for sharing your knowledge. Thank you to our audience for attending today's webinars. As a reminder, the recordings and slides will be up on 3 to 4 business days. If you are eligible for CEs, you will also be receiving a detailed email within the next 2 to 3 business days. I encourage you to visit our website, ctacny.org, for past and future offerings. And again, on behalf of CTAC, our presenter, we do thank you for joining us today and have a great rest of your day.
And let me just thank everybody for attending. Thank you for doing the work you do. You're clearly here because you like youths. And I want to close with a message that one of our best tools, not just in the work I do with specialty substance use, but in the work you do with broad mental health and other interventions, one of our best tools is therapeutic optimism. That is conveying a sense of hope and encouragement that people can and often do get better, and we'll never give up, and we're willing to keep working with people and see them through. So keep at it.
Thank you so much. Well said. Thanks all.